Well, Dr. Tahir, excellent talk and great cases, great demonstration of your skills. We know Tahir Shah is doing great work in Peshawar, and in fact, he's doing a lot of CTOs. He was just sharing them. और स्टेज होता है ऐसा है ना, स्टेज मेनिया जो होता है एक बार स्टेज पे आना होता है, छोड़ना मुश्किल होता है. But that is my part of the job being a moderator over here is we have to finish in time. I think we are already late 25 minutes. So in the interest of time, we can have a couple of comments or questions from the panel of experts. I wish we had some time. You've got nice group of panel of experts sitting there.
Yeah, Salman, excellent talk. It was an excellent talk. I always wanted to ask you one question about the importance of right heart cath prior to any kind of complex left heart procedures, like complex CTOs and complex bifurcation techniques.
Thank you. That's a good question. So I think, CTOs should probably not be done, as Tahir Sahab said, shouldn't be done ad hoc. So this should all be planned procedures. And part of planning is to make sure that the patient is not in heart failure. We do CTOs in patients who have low ejection fractions, but there are often patients who are clinically compensated. So I have a very low threshold for doing right heart cath because I think a lot of people, at least that I see, tend to have low-grade heart failure, maybe sometimes diastolic dysfunction, a lot of pulmonary hypertension in older patients. But anytime you plan to do a procedure that's going to be 2 or 3 hours long, you need to know what the starting hemodynamics are, especially if the EF is not normal. So if the EF is not normal, or if the patient has a history of heart failure, I think it's a good idea to do that.
So if the patient has high PA pressure and the LV is a little bit down, would you stop your ad hoc procedure or just carry on with it?
I think it depends. If the EDP is very high, if the EDP is 36 or 40, then I probably may give them diuretics and wait and see how they, because sometimes patients start becoming very uncomfortable during the case. It is a long case, and if the patient starts becoming uncomfortable, the blood pressure starts rising, and then they go into flash pulmonary edema, which can be scary. I do know that there's some places that mandate that anesthesiology be involved for all CTO cases. Again, I think it's from institution to institution. But I think if you can optimize the heart failure, that's better. But remember, CTO is not an emergency. That artery is already 100% blocked. So to rush in to do a CTO and then have a complication is hard to justify that. Right? Okay. So
I think it's not going to be the last session. We are going to have 3 days more ahead. So we're going to have a lot of stuff in the coming 3 days. So thank you very much, everyone, for coming over here, for sparing your time. And from here on, I give my job to Dr. Amber Ashraf. Is she here for the next session?
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I do understand all of you are tired, but it's really a wonderful activity, and we are going to start our fifth session. As we are running short of time, I would not take much of the time between me and your speakers. First of all, I would like to request our chairs, please come and join us on the stage. We have a wonderful chairs here, Professor Dr. Naeem Aslam. We all know him very well, former president of Pakistan Cardiac Society, and he's CEO of. Then I would like to request Professor Dr. Nadeem Hayat Malik Sahab. Sir, would you like to join us as a chair, because few of our chairs are not here and we have modified the chairs. I'm really grateful and thankful. Ji. Now I would like to request General Sohail Aziz Sahab. These are our wonderful leaders, and we don't need a word for their introduction. Ji. Dr. Qazi Abdul Sabur, you are here? Okay, thank you. Please come and join. Dr. Salman Arain is here, and we would like to have his comments on this very wonderful session on coronary artery disease, TAMI, and acute coronary syndrome. I would like to request Dr. Junaid Zafar. Is Dr. Junaid Zafar here? Right. Fawad Farooq sir, he is not here. Then Dr. Nabil. Dr. Nabil is here? Okay. Dr. Muhammad Dabil Akbar Chaudhry, he's around. Please come and join us as a chair. Dr. Khalda Sumro, she is going to join us on the Zoom. And fine, right, Ji. Now, Dr. Numan Nasir is here. Would you like to join? Please come and join because I have to fill the chairs. Thank you. And we would love to have your wonderful comments. So, our first speaker is Dr. Ataur Rehman Quraishi. He's an intervention cardiologist from Canada, and we are going to take him on the Zoom. Do you have his presentation? Okay, Ji. And his talk is CABG versus PCI in multivessel coronary artery disease. Guidelines update.
Thank you very
Assalamu alaikum,
much.
Ji.
Hear me well? And can you see my slides, please? Are you seeing the slides? Hi, everyone.
No, sir.
Please share the screen.
I'm
Slide
sharing
sharing?
the screen.
Okay, just wait for a minute. Dr. Ataur Rahman, would you like to introduce yourself? Yeah, now we can see your screen.
Thank you very
Please
much.
go ahead.
So, Assalamu alaikum, and very nice to be back among friends. I can see some old names that when I was there, Dr. Sohail Aziz and Dr. Neem Hayat Malik and Dr. Khalda Sumro. Assalamu alaikum to all of you and all my other colleagues. It's really nice to be here among you. Thanks to all the organizers for the invitation. I won't take a lot of time in my introduction. Time is only 10 minutes. I'll try to stick to that, try my best. The topic given to me was CABG versus PCI and multivessel coronary artery disease, the guidelines update. I don't have any disclosures as such relevant to this talk. What I'll try to do is to outline what are the guidelines, what is the available evidence, and then try to discuss a couple of recommendations after discussing the available evidence. So just start with a case. 77-year-old male, type 2 diabetes, hypertension, with history of prior stroke, mild residual left hemiparesis, walks with a cane, eGFR of 32. He still drives and lives alone. Manages all the routine household chores. So the dominant came in with ongoing stable angina and some history of shortness of breath and exertion. Dominant RC has a long segment of 90% stenosis, EF 32%, and that's his left side. So what do guidelines tell us to deal with such kind of patients? It does not fit, and you will see several other examples in your real life that may not fit the guidelines. What are guidelines? Guidelines are a general rule, principle, or a piece of advice. It may not apply to 100% of population, but it is for majority of patients that we deal with. So it provides a general idea based on the evidence. Based on the evidence of randomized studies, registries, non-randomized data, and some of the guidelines recommendations are based on consensus data. So the guidelines I'm going to discuss and trying to quote, we'll try to quote today is the most recent one is the ACCHA SKY guidelines for arterial revascularization. And I'll limit myself to multivessel CABG versus PCI discussion. So the guidelines comes with recommendations. Guidelines comes with quality of evidence. The level of recommendation, the class of recommendation, the strength of recommendation can be divided, as we all know, for a long time from class 1 to class 3 recommendations. Class 1 is the strongest, class 3 has been further subdivided regarding whether class 3 with no benefit and class 3 with harm. Levels of evidence can be the highest evidence with high quality multi-center randomized controlled studies to meta-analysis of high quality studies or more than one randomized studies. Or these are the level A. That's the highest quality of evidence. Level B with randomized data, level B with no randomized data. And when there is limited data and expert opinion, all these make up our strength of our recommendations, the quality of evidence. So always, what do we expect? I think before going on to the evidence, I thought I'll ask myself, what do I expect from the revascularization? Whether it's CABG, bypass, what am I expecting when I'm dealing with a patient who has multivessel coronary artery disease? What the patient should expect when I'm taking the consent, obtaining the consent, what should I be telling the patient? And one is improved survival. We all know that. Everybody wants to have a better survival. Symptom relief is another important feature that you expect from revascularization. Quality of life. Some people that we know that the quality of life may deteriorate after a particular procedure, like if you're operating on an 80-year-old performing bypass surgery, the quality of life initially will definitely go down significantly. We know from the data, a lot of these patients may end up in the nursing home and people may not want that. The quality of life is extremely important. So patient perspective regarding quality of life is very important. The reduction in hospitalization, ischemic and heart failure symptoms, and low risk of complications. So our procedure should be low risk, whatever we are offering. So medicine, as we all know, is an art. Guidelines can be applied as general to the majority of people, but we need to make patient-specific decisions, and for that, we have to take all these things into consideration. So what is the available evidence? I'll only go over 4 or 5 studies that have a major impact on the guidelines and how we see the guidelines in the current era. I won't go into very detail of the studies. I'll be very superficial based on the time allocated. To start with, this study called the BEST study came from Korea. Dr. Sunjin Park was the main investigator. The BEST trial investigator published in the New England Journal of Medicine 3 years ago. It compared patients with multivessel coronary artery disease undergoing PCI versus bypass surgery. Close to 900 patients, 950 patients underwent procedure were participating in the history in the study. As you can see, majority of the patients had more than 3 stents, 3.4 stents, total length of stents close to 85 millimeters. 70%, 71%, 72% had IVUS. But the complete revascularization, the PCI arm was close to 50% or 51% only. In the CABG group, the arterial grafts, this is an important thing to remember and I'll come back to it, was close to 2 arterial grafts per patient. And the complete revascularization was possible in about 71% of patients, significantly higher compared to what we achieved in patients who are undergoing percutaneous intervention. So these were the results. This was the primary composite endpoint of death, myocardial infarction, and stroke. There was statistically significant in patients undergoing bypass surgery, had a better outcome compared to those undergoing PCI. If you added repeat revascularization, the difference was wider. And this was over a period of 5 years. We know that when we are offering these treatments, we are offering for long-term success, not 1 year, not 2 year success within the next 5 to 10 years, how your patient is going to do in terms of repeat procedure, in terms of death, myocardial infarction, and other events. Going to another study, that is patients with diabetes, the FREEDOM study. And this was published in 2012. And it clearly told us that not only composite endpoint was significant in patients with, who had diabetes and multivessel coronary artery disease, the outcome of death and primary composite endpoint was significantly better in patients undergoing bypass surgery. And we have, so should all patients with diabetes undergo bypass surgery? Does this trial tell us? No. I think the trial, one has to look into details of the trial. Mean stent length that was used in this study was close to 100 millimeters. The stent was used. Long stents, multiple stents, and We don't have, I think the syntax score was not reported in this one, but these patients probably had high syntax score as well. So again, patient characteristics, patient's anatomy should come into consideration, but the study tells us when we're performing PCI or bypass surgery in patients with complex and multivessel coronary artery disease, bypass surgery provides better outcome compared to PCI. Syntax, a lot of you probably know syntax and have seen the 5-year data. More recently, a 10-year data was published from the syntax study. Syntax study used tax resistant, performed several years ago, and compared PCI versus bypass surgery in patients with left main and multivessel coronary artery disease. We know that all-cause death was not significantly different among patients undergoing bypass surgery or PCI, although there was a trend towards better outcomes with bypass surgery, but it was not statistically significant at 10 years. But what was interesting to see, again, the complete revascularization was more in patients undergoing bypass surgery versus PCI. And if you look at data based on complete or incomplete revascularization from this study, it tells you that patients who had complete revascularization, overall, their outcome was almost similar, as you can see it right here. The lines are overlapping at 10 years. No significant difference, but the difference came when patients received incomplete revascularization. In isolated left main coronary artery disease with low syntax score, PCI, in fact, provided better outcomes compared to heart surgery, whether it was complete or incomplete revascularization, PCI had the worst outcomes. So again, important lesson we need to learn from these studies that when we are performing PCI as a primary procedure in these patients who can undergo bypass surgery, but they chose to or prefer PCI, then we need to make sure that we are providing complete revascularization in these patients who have low or who have less complex anatomy. When we perform incomplete revascularization, the outcomes are worse compared to bypass surgery. Excel, there was a lot of controversy about the Excel study. When it was initially published, the first 2-year data suggested the PCI had significantly better outcome. There was controversy how the MI was calculated in this study. But if you look at the composite endpoint and death, myocardial infarction, stroke, at 2 years or 2.5 years, the lines crossed. And again, bypass surgery had a slightly better outcome, not statistically significant, p-value of 0.13. But combining with ischemia-driven revascularization, bypass surgery definitely had better outcomes over 5 years in the Excel study as well. And you can see that in this slide as well, the ischemia-driven, if you take each endpoint separately in every segment, bypass surgery had a better trend. So this last study that I'm going to share with you all is overall cause-specific mortality. This is a meta-analysis published in 2020 in JAMA Internal Medicine. 23 studies, high-quality studies, 13,000 patients, mean age range of 60 to 71 years, mean follow-up of 5.3 years. PCI was associated with high rate of all-cause and cardiac mortality in these patients in the meta-analysis that was published in JAMA. But it did not reach statistical significance. The heterogeneity p-value was 0.08. Certain studies definitely showed that there was benefit related to bypass surgery. Very few studies showed benefit purely related to PCI, but a lot of the studies showed an equipoise, but majority of the studies showed benefit or trend towards better outcomes associated with coronary artery bypass graft surgery in patients with multivessel coronary artery disease. So what does the recommendation say? I'll just go over very few recommendations, which
Dr.
I thought were
can you listen me? Dr. Ataur Rehman, can you listen me?
Yes.
Already your time has finished. You have 2 more minutes. Try to wind it up. Thank you very much.
Thank you very much. So, general recommendations when optimal revascularization are unclear, a multidisciplinary approach. The heart team approach, as we discussed earlier, Dr. Srivathi's presentation as well, is important at every center. What are the factors that are considered by the heart team? Coronary anatomy, comorbidities, procedural factors, which include very important thing, what is your local outcome? What is your local expertise? That has to be considered very carefully, and the patient factors, patient shock, what our patients believe, what are the social support is available, and what is patient's preference. So these are the factors to be considered by the heart team. When you look at left main disease, multivessel disease, the guidelines suggest patients with significant left main disease, surgical revascularization improves outcomes with a high class of recommendation and good level of evidence. PCI is reasonable in these patients with left main disease, but the class of recommendation is 2A with medium complex, not complex disease. When it comes to complex disease, bypass surgery should be chosen over PCI to improve survival. And in patients who require multivessel with higher syntax score, it is reasonable to choose PCI over bypass over PCI. Again, class 2A recommendation. But when left main is involved, patients with diabetes, this is a class 1 recommendation. Patients with triple vessel disease to undergo surgical revascularization and percutaneous intervention only if they are poor candidates for surgery. That's a class 2A recommendation. When it comes to LV dysfunction, the significant LV dysfunction, less than 35%, bypass surgery is preferable to coronary artery PCI. And in patients with moderate, even with moderate LV dysfunction, bypass surgery is preferable, especially if somebody is using a left atrial ambulatory valve. In patients with normal ejection fraction and three-vessel disease, it's a class 2B recommendation. The benefit versus risk compared to medical therapy, and multiple studies have not shown to be significant. It's mostly for symptom control, and that's why it's a class 2B recommendation. And PCI is for both PCI and bypass surgery, not one over the other.
Professor Dr. Ataur Rahman, really I do appreciate it's a very lengthy topic and the way you are going ahead. Thank you very much.
This is my last slide.
Okay, thank you, Ji, please.
In older adults, all patient treatment strategies should be based on an individual patient preference, cognitive function, and life expectancy. So I'll stop here. Again, coming back to this, how would you treat with it? I'll leave it up to you. I won't go into that discussion. It will be based on your local data and based on your local expertise, if you can, and patient preference. The heart team approach in such kind of case will be key to make a decision. I'll end there. Thank you very much. Again, very sorry. I tried to rush myself, but very sorry for going over time.
Thank you, Dr. Atta. We do understand it's a very huge topic and you did it very nicely. A quick one comment from the panelist. Anyone? Ji, Dr. Salman.
Can you hear me? I think this is a common situation that we come up against. I think the big challenge for me here is the patient's ability for cardiac rehabilitation. And without having seen the patient, he had a prior stroke, he lives by himself. And patients who've had bypass surgery need a lot of care at home. Now, if your social setup is such that you can get home health, I think that's reasonable. Having said that, I think the lesions were focal enough that PCI may also be a reasonable option. But again, this really comes down to the heart team approach. And again, it's very hard to say just looking at the angiogram.
Thank you, Dr. Salman. We are running short of time, and that's why, thank you, Dr. Atta. It's really a very wonderful, nice talk. Now I would like to move ahead to our next speaker, and that is Professor Dr. Tariq Ashraf. His talk is on STEMI, acute coronary syndrome, and multivessel disease, treatment of non-culprit vessel in a stable patient. Hand it over to Dr. Tariq.